From the JAMA Network, this is JAMA Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Welcome, JAMA Surgery listeners. This is Amalia Cochran, the web and social media editor for JAMA Surgery. And I'm here today talking about breast cancer risk after bariatric surgery and the influence of insulin level. The authors who are meeting with me today are Dr. Felipe Kristensson and Dr. Magdalena Taube from the University of Gothenburg in Gothenburg, Sweden. My first question for you is simply one of the motivation for your work. What led to your curiosity about the impact of bariatric surgery and particularly post-procedure insulin levels on the incidence of breast cancer?
Yeah, hi, Amalia. Thank you for your question and thank you for having us. Our research group has been exploring the effects of bariatric surgery on obesity and obesity-associated diseases for several decades, but it's not until quite recently that we have been able to explore the effects on cancer risk due to the long time it takes to develop cancer. Furthermore, we did not only want to look at the effects of bariatric surgery on cancer risk, but also try to explore the underlying mechanisms behind obesity and cancer development. We found insulin especially interesting as a potential mediator between obesity and cancer, as it has been shown that obesity often increases insulin levels. It also itself constitutes an important cellular growth factor that promotes cell proliferation and inhibits cell apoptosis. It has previously been shown that bariatric surgery lowers insulin levels, and we therefore wanted to explore both the effect of bariatric surgery on cancer risk and if this risk may be affected by preoperative levels of insulin. We choose to look at breast cancer specifically, both because it's the most common cancer type in women, and so far there are only data from retrospective studies, but also due to a previous study where we explored the effect of bariatric surgery on female cancers in women in the Swedish obese subject study. We previously found that women with obesity and hyperinsulinemia had the greatest risk reduction for female cancer after bariatric surgery. And this, of course, made us curious if the same association could be found for breast cancer specifically.
I do think it's important for our listeners to understand the data set that you all used for this study, which you mentioned, the Swedish obese subject study, both because it's a pretty unique data set and because, as you mentioned in your answer to that first question, that this is a very mature line of research that you all have been working on for a long time. Can you please give our listeners a brief description of the Swedish obese subject study and explain what both the benefits and the limitations of this study data are, particularly as that pertains to your current research question?
Thank you, Amalia, for that question. The Swedish obese subject study is a non-randomized intervention study designed to offer controlled prospective long-term conditions to investigate the effects of bariatric surgery and weight loss on mortality and disease outcomes. The SOS study started in 1987, enrolling patients from 480 health centers and 25 surgical departments all over Sweden. In the SOS study, we investigate the effect of bariatric surgery comparing a group of 2007 individuals who have undergone bariatric surgery, and they constitute the surgery group. And we compare them to a control group of 2,040 individuals who received standard obesity treatment at the health centers. Inclusion criteria was 37 to 60 years of age and a body mass index of 38 or above for women. And the strength with the SOS study is the long follow-up time of 36 years at present, and the access to collected comprehensive clinical data and biochemical measurements. And of course, the SOS database, which is cross-checked against Swedish high-quality national registers, like, for example, the Swedish Cancer Registry. And we do that on a yearly basis. A limitation for this study is that we have no information on estrogen levels or breast cancer subtype.
I do think that's an interesting limitation about what we don't know, again, just because of the data that was collected about the breast cancer subtypes.
Yes.
Mm.
One of the things that occurs to me is that since you all have been collecting this data since 1987, we know that the surgical management of breast cancer has evolved substantially over the last greater than 30 years. Also, over that period of time since 1987, there has been substantial evolution in how we manage metabolic and bariatric surgery, and the operations have changed, and some of them have become obsolete as we've figured out better ways of doing these things. And it would seem to me that that also is potentially something that would impact your findings with this.
You are absolutely right that some of the surgical methods used in the SOS study are no longer in use in the clinic. However, the magnitude of weight loss in our study is similar to the surgery techniques used today. And other studies have shown that the reduced cancer risk associated with bariatric surgery is closely linked to the degree of weight loss. And therefore, we believe that our results are valid also in today's context.
Why did you think that it was important to not simply look at insulin levels, but to include a variable specifically looking at insulin resistance?
Well, this is because hyperinsulinemia is strongly correlated with hyperglycemia, and they both constitute a major part of metabolic disease. Hyperglycemia has also been suggested as a mediator of increased cancer risk. It can act both as a substrate for cell proliferation, but may also increase DNA damage through increased production of reactive oxygen species, promoting oncogenesis. So, in an attempt to evaluate the separate effects of hyperinsulinemia and hyperglycemia, we used the so-called homeostatic model assessment for insulin resistance, or HOMA-IR, which is a tool to estimate insulin resistance based on fasting insulin and glucose levels. So using the HOMA-IR, we can see in figure 4 in our article, which is a forest plot of hazard ratios for different risk factors to breast cancer, that insulin as well as HOMA-IR has a significant interaction effect with breast cancer risk, whilst the blood glucose does not. And although this is by no way conclusive, we believe it favors the notion of insulin as an important mediator of breast cancer risk in our study compared to glucose levels.
I found figure 4 that you just alluded to be very interesting, but I also really want to point our readers to the supplemental figure 4, because it is incredibly striking the wide difference in the incidence of breast cancer for patients who were above insulin median. Can you help me to better understand what the importance of that particular finding is?
Yes, so both figure 4 as well as figure 3 shows the cumulative incidence of breast cancer in the surgery and usual care groups stratified by median baseline insulin levels. So what we can see is that in women with baseline insulin levels above the median, bariatric surgery is associated with a 52% risk reduction for breast cancer compared to usual obesity care. When excluding for breast cancer cases within the first 3 years after study entry, which is what we can see in figure 4, the effect is even greater, showing a 58% risk reduction for breast cancer. Whilst in women with baseline insulin levels below the median, there were no risk reduction for breast cancer after bariatric surgery compared to usual obesity cares in either of the figures. So our results suggest that the benefit of bariatric surgery on breast cancer risk is associated with baseline insulin levels. And this further suggests the important role of insulin in cancer development. So our results both help in increasing our understanding of insulin control and cancer prevention, but it also helps identify those individuals who may benefit most from bariatric surgery.
Where are you headed next with this work? What is the next question that you're hoping to explore in this space?
Our next step is to try to find the genetics behind these results. We want to explore certain polymorphisms that is known to be associated with obesity and breast cancer, and also to explore if these polymorphisms are also associated with the insulin.
We both want to look at polymorphisms that already have a known association with breast cancer, but we also want to look a bit into polymorphisms that are associated with metabolic disease and the outcomes of bariatric surgery, and to see if these polymorphisms also affect the treatment benefit from bariatric surgery regarding breast cancer outcome.
I think these are some fascinating connections that you all are working to build out in how we understand two, typically thought of as separate disease processes. Felipe and Magdalena, thank you both so much for your time today. I really appreciate you sitting down with me to help us get a deeper understanding of the work that you're doing right now.
Thank you.
Yeah, thank you very much.
This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.